Alright, let's move on from heme synthesis to coagulation homeostasis. Homeostasis is obviously important to make sure you don't bleed too much after an injury, and there are three stages. Do you know what these three stages are? Well, first is vasoconstriction to decrease blood flow, then primary hemostasis, which involves platelets forming a plug, and third is secondary hemostasis, in which clotting factors ultimately result in a fibrin mesh network to reinforce the platelet plug. Before we discuss disorders of coagulation in greater detail, let's first look at our tests for coagulation. First, we have prothrombin time, or PT, which tests the function of factors 1, 2, 10, 5, and 7. Importantly, this is the common pathway, and factor 7, which means a defect in the extrinsic pathway will lead to an elevated PT. In contrast, partial thromboplastin time, or PTT, tests the function of all factors except 7 and 13. Therefore, if there is a defect in the intrinsic pathway, this will lead to an elevated PTT. These labs become important when we discuss many of our coagulation disorders. Do you recall the deficiencies in hemophilia A and hemophilia B? Well, in hemophilia A, there's a deficiency in factor 8, and in hemophilia B, there's a deficiency in factor 9. Also, hemophilia C is good to know for your exam, and that is a deficiency of factor 11. So which test would you expect to be abnormal in these disorders? Since these coagulation factors are in the intrinsic pathway, they will elevate PTT. And since factor 7 in the final common pathway, which includes factors 2, 5, and 10, are all functioning normally, the PT is unchanged. Clinically, patients will present with large contusions and hemorrhages, particularly with bleeding into their joints called hemarthroses, which is a pretty specific sign for hemophilias. So if you see hemarthroses on your exam, the first thing you should think of are these hemophilias. Do you recall which of these is the most common hemophilia? That would be hemophilia A. And what would we expect these labs to show in a vitamin K deficiency? Well, as we discussed previously, vitamin K deficiency leads to a defective production in factors 2, 7, 9, and 10. These factors span both the intrinsic and extrinsic pathways, so the expectation is that there would be an increase in both the PT and the PTT. However, it is notable that the PT is better for testing for vitamin K deficiency because the entire extrinsic pathway is deficient as well as the common pathway. Now that we've talked about some of our major coagulation disorders, let's move on to our platelet disorders. If PT and PTT tell us how well our coagulation factors work, bleeding time is the one way to check how well our platelets work. Bleeding time is a test that they really don't do much on patients anymore, but to perform the test you make a small cut in the patient and simply time how long it takes them to stop bleeding, which would indicate that a platelet plug is formed. When platelets are defective or deficient, you will expect bleeding from the mucous membranes, such as epistaxis, a pretty fancy word for nosebleeds, or bleeding from the gingiva. You will also see microhemorrhages, petechiae, and purpura. To compare with clotting factor disorders, platelet disorders give you prolonged bleeding and mucosal bleeding, while coagulation factor disorders have delayed bleeds because the initial platelet plug forms well, but bleeding occurs later in time due to the immature and weak structure of the clot without appropriate clotting factors to stabilize it. The bleeds due to coagulation factor disorders are also classically deeper, such as into the joint spaces. Do try to remember prolonged versus delayed bleeding in platelet disorders versus coagulation disorders. The first example of platelet disorders is a subject we spoke about in physiology, and that is Bernard-Soulier syndrome. Do you recall the genetic defect here? That would be our GP1B receptors that bind the activated von Willebrand factor. A defect here would lead to a decrease in the platelet to collagen adhesion. This disease is also characterized by abnormally large platelets. What would you predict for our platelet count and bleeding time? Our bleeding time would increase due to the adhesion defect, and it may also result in fewer larger platelets, so we may see a decrease or perhaps a normal platelet count. The second disease is Glanzmann's thrombocythemia. This would be a genetic defect in what receptor? That would be GP2B3A receptors, which are responsible for the aggregation of platelets. Since this type of aggregation does not occur, there would be no platelet clumps seen on peripheral smear. What would our test show? Our test would indicate a normal platelet count and an increased bleeding time. In idiopathic thrombocytopenic purpura, patients will have platelets with decreased survival time as a result of the autoantibody anti-GP2B3A and therefore peripheral destruction of platelets. What would you expect in our lab tests? Well, here you'd expect to see a low platelet count and an increased bleeding time. In many cases, patients simply have low platelet counts without any symptoms that cause them to present to the hospital. Conversely, patients with thrombotic thrombocytopenic purpura are usually very sick. In this case, there is also a decreased platelet survival, but the reason is very different. Here, there is some inhibition of Adams 13, which is a metalloprotease that usually degrades von Willebrand factor multimers. If you can't degrade von Willebrand factor multimers, you get these big von Willebrand factor multimers that run around and grab onto platelets and cause them to aggregate all over the body, resulting in tons of clots. There is widespread shearing of RBCs in a microangiopathic hemolytic anemia mechanism, which gives off schistocytes and increased hemolysis markers like LDH. The classic pentrad of symptoms you'll want to remember for TTP is fever, microangiopathic hemolysis leading to schistocytes and anemia, thrombocytopenia, renal failure, and neurologic symptoms. These can be remembered with the memory aid FAT-RN, which stands for fever, anemia, thrombocytopenia, renal, and neurologic. It is important to remember that the other microangiopathic hemolytic anemia, hemolytic uremic syndrome, or HUS, presents with just the three middle letters of this mnemonic, meaning only anemia, thrombocytopenia, and renal failure. HUS does not feature fever and neurologic symptoms, and that is how you can tell these two diseases apart. Treatment for TTP is emergent exchange transfusion to clear the body of these von Willebrand factor multimers and steroids. So what would you expect to see in TTP for our platelet count and bleeding time labs? Well, these labs look similar to ITP, and then we have decreased platelet count and increased bleeding time. Now let's turn our attention to combined platelet and coagulation disorders. We've discussed all of these labs previously, and in the mixed disorders we'll see changes in all of them. In von Willebrand disease, there is a defect in the amount of von Willebrand factor, which leads to defective platelet plug formation, specifically in the platelet to collagen adhesion. And what platelet disorder has a similar result? That's our old friend Bernard-Soulier syndrome. A secondary coagulation effect of von Willebrand's disease results because von Willebrand factor usually carries factor VIII protectively in the circulation. This coagulation effect is not seen in Bernard-Soulier syndrome. When von Willebrand factor is deficient, factor VIII may also become deficient, as it is exposed and has lost its protective carrier in the blood. What would this do to all of the labs listed here? Our platelet count is going to be normal, since there is no issue with them in von Willebrand's disease. Our bleeding time would be increased due to the defective adhesion and therefore activation and aggregation of platelets. PT would not be altered, as the extrinsic system is not affected. And lastly, there is a possible increase in PTT, as factor VIII is only a cofactor in the intrinsic pathway. In most cases, this disease is mild. It is important, though, because it is the most common inherited bleeding disorder, and is transmitted in an autosomal dominant manner. So how do you diagnose this disorder? We use the ristocetin assay, which induces the GP1B receptor, such that if von Willebrand factor is present, they will bind. If you do not see agglutination after the addition of ristocetin, that means there is no von Willebrand factor to bind to the available GP1B receptors. And what is the treatment? The treatment here is desmopressin, which you may also remember is DDAVP from the endocrine chapter and diabetes insipidus. Since desmopressin is an analog of ADH, it is used in the treatment of central diabetes insipidus to replace the missing ADH and promote reabsorption of water from the collecting ducts. The other interesting aspect of DDAVP is that it induces the release of von Willebrand factor that has been stored in the endothelium. Disseminated intravascular coagulation is the other combined platelet and coagulation disorder and is very serious. Here, there is a widespread activation of all clotting factors, which leads to a deficiency in these clotting factors and thereby creating a serious bleeding state. All of this activation leads to small thrombi throughout the body, which consumes all of our platelets, and as before, leaves us with schistocytes, decreased fibrinogen as it is used up, and increased fibrin split products like D-dimers, as all the fibrin mesh network that is unnecessary is broken down in the vasculature. Causes include sepsis, particularly gram-negative sepsis, massive trauma, obstetric complications, acute pancreatitis, malignancies, and nephrotic syndromes, as well as blood transfusions. These can be remembered with the mnemonic, "Stop making new thrombi." So what do we expect from our lab panel? Platelet count is going to be down due to all of the thrombi. Bleeding time is going to be up due to the loss of the platelets. The PT is going to increase due to the loss of the extrinsic pathway and the common pathway, and the PTT is going to be increased due to the loss of the intrinsic pathway and the common pathway. Abciximab is a monoclonal antibody that inhibits the GP2B3A receptor and therefore mimics the pathology of what disease? Recall that this would mimic Glanzmann's thrombocythemia, as this is a deficiency in the GP2B3A receptor itself. Now that we've discussed the platelet disorders, the coagulation disorders, and the combined platelet and coagulation disorders, we should turn our attention to the opposite problem, which is hypercoagulability. The first hypercoagulable state is antithrombin deficiency, which features an increase in venous clots. From its name, it's pretty clear what the etiology of the disease is, but do you remember the function of antithrombin? Antithrombin breaks down several of the coagulation factors, and a deficiency of this enzyme would allow for coagulation factors to continue working. Coagulation tests such as PT and PTT are not affected in this disorder. However, patients with antithrombin deficiency are known to have heparin resistance. So, if you were to add heparin to a patient's blood with antithrombin deficiency, the increase in the PTT after administration of heparin would not be as great as if you had added heparin to a normal person's blood. This is because heparin only works by enhancing endogenous antithrombin, and thus, in a patient with low antithrombin levels, the effect would not be as great as in a person with normal antithrombin levels. Do you recall from our previous discussion the resulting defect from the factor V Leiden mutation? This mutation alters the structure of factor V, which does not allow protein C to deactivate it. However, it does maintain the natural function of factor V. This is the most common cause of inherited hypercoagulopathy, is predominantly in whites, and usually leads to venous clots. Since protein C and S lead to an inactivation of factors 5A and 8A, it would make sense that a deficiency in these would lead to a decrease in inactivation of these factors, allowing them to continue working. This leads to an increased risk of thrombotic skin necrosis and hemorrhage in patients who are given warfarin without first properly anticoagulating the patients with heparin. This is because if you already have a deficiency in protein C, then you add warfarin on top of this, you will deplete the remaining protein C. All you're going to be left with is coagulation factors that are not yet inhibited by warfarin because it takes several days for these normal coagulation factors to be decreased. So basically, you're going to have no anticoagulation factors to fight your normal coagulation factors. This effect of skin necrosis from warfarin is very specific on your exam for protein C and S deficiency, so be sure to know the relationship. Protein C and S deficiencies are known to form venous and non-arterial clots. The next syndrome is prothrombin gene mutation, which leads to an overproduction in prothrombin, and therefore a hypercoagulable state associated with an increase in venous clots. So how about we quickly review? Factor V increases coagulation, And as the Leiden mutation decreases our ability to turn off factor V Leiden will give us a hypercoagulable state. Prothrombin increases coagulation, and the prothrombin gene mutation leads to too much prothrombin, and therefore a hypercoagulable state. Antithrombin and protein C and S inhibit coagulation, and thus a deficiency in these enzymes is going to lead to a hypercoagulable state. Remember on the boards that when any of these genetic predispositions are combined with environmental states or behaviors that promote thrombi, like pregnancy, smoking, being on oral contraceptives, taking a long airplane flight, or long-term stasis, you should be looking for symptoms of pulmonary embolus or thrombus. Now let's turn our attention to blood products. There are multiple options that we can give patients when we need to transfuse them with blood products. For people with acute blood loss or very severe anemia, we can provide packed RBCs that will increase the hemoglobin and oxygen carrying capacity very quickly. If the problem is significant bleeding secondary to low platelets, what would be the simplest correction to make? That would be transfusing platelets to specifically increase the platelet count. If the problem is due to a loss of coagulation factors, such as in DIC, cirrhosis, or warfarin toxicity, what can we give these patients? Patients can receive fresh frozen plasma, which will increase almost all coagulation factors by about 20%. Finally, if the problem is that fibrinogen, factor VIII, and or factor XIII are deficient, what blood product should be administered with this patient? At this time, cryoprecipitate is necessary, which contains these factors at high concentration. Cryoprecipitate is actually made from distilling these specific factors out of fresh frozen plasma and concentrating them. Remember that transfusion of any blood products carries at least some risk. There is a risk of infection, transfusion reactions, iron overload with enough transfusions, and hyperkalemia, since RBCs can lyse when the blood is stored for a long period of time, releasing their potassium. A final interesting pearl about transfusions, and something that has previously come up on boards, is that if your patient has major trauma and receives a large volume transfusion, say 5 or 6 liters, you might see them become hypocalcemic afterwards. This is because citrate is added to the transfused blood as a preservative, and this citrate can actually chelate calcium at some point in the patient's blood. Things you can do to prevent hypocalcemia include using fresh blood if at all possible, transfusing slowly, and keeping the patient warm, since hypothermia can intensify this reaction. Fresh blood may actually come from the patient. For example, if you put in a chest tube in a patient with a hemothorax, you can recycle that drained blood and immediately auto-transfuse it back into the patient.